Hello and good afternoon, TVI viewers. Welcome to CrossRoads with Neethan Shan. As you know, CrossRoads is a weekly talk show dedicated to discussing a variety of topics that are relevant to the social, economic, political, and cultural advancement of Tamil Canadians. Yesterday, on March 21st, all around the world, we marked the International Day for Elimination of Racial Discrimination. There is a belief among some of us that racism is a thing of the past, or that racism does not exist in Canada. There is also a very limited understanding in the general public as to how systemic racism operates in our society in Canada. In today's episode, we will mark the International Day for Elimination of Racial Discrimination by exploring the prevalence of racism within a specific sector, within a specific field, healthcare and health in general. To discuss this topic, I'm joined here by three special guests who have experience in both the theory and practice in health. Gayathri Naganathan holds the Masters of Science from the Institute of Health Policy, Management and Evaluation at the University of Toronto. She has experience with health research and policy for vulnerable population, including racialized homeless individuals with mental illness. She currently serves as a research associate at the Center for Refugee Studies at York University and as a research associate at the Health System Performance Research Network at University of Toronto. Welcome, Gayathri.
Great to be here.
Next guest is Anjum Sultana. Anjum is a Masters of Public Health student at the Dalai Lama School of Public Health at the University of Toronto. She worked as a research and public health programming focused on immigrant, refugee, and non-status women access to mental health and sexual health services in Toronto. Thank you very much, Anjum, for joining us.
Thank you for having me.
And our third guest is Dr. Farah Islam. Dr. Farah Islam is a postdoctoral fellow at the Center for Addiction and Mental Health, CAMH, and the University of Toronto. She researches the impact of racialization and migration on mental health. Her current project is exploring the mental health and services access experience of South Asians, particularly youth living in Peel region. Welcome, Farah.
Thank you so much, Neethan.
Okay, so we'll get into the topic right away. We are marking the International Day for Elimination of Racial Discrimination. As I mentioned in my introductory remarks, sometimes there's the belief that racism does not exist in Canada. It's something of the South or somewhere else, and particularly health sector. Health is universal, quote unquote, in Canada, and we don't believe that health system has any racist parts to it. So let's start with making the connection between race and health. So Gayathri, I'll start with you. Is race a determinant of health? Does race determine how healthy we are, and how so?
Well, I would say definitely race is a determinant of health, and there's definitely a lot of data to back that up in terms of disparities, so differences in the way that racialized people or people of color experience different healthcare conditions than non-racialized or Caucasian or white or however we want to categorize that. So there's definitely data to support that idea. And race, just like, it's a social category, it's a social idea, a social construction. So it's not a biological concept. So just as any other social issue like low income, lack of access to education, lack of access to healthcare, these are all different social lenses through which we can understand health. And just as these other concepts like gender equity and all these other things, race also has an impact on health and how we experience it as well.
So, Farah, you've done a lot of research on this topic as well. So how do you see race or the impact of race manifest itself in the health outcomes for people?
Absolutely. So one of the mechanisms, the way race actually impacts health, is often through racism, which I think we'll absolutely discuss in this panel. People of racialized populations often don't have the access to mental health care or to health care in general that they really should be getting, and aren't treated the same when it comes to the mental health care system.
What about public health when it comes to generally public health as well?
Yeah.
Is race a key determinant of how people can access public health?
Definitely. So race is a determinant of health, and there's many determinants, social determinants of health, and sometimes race, what race you belong to, also impacts your access to things like housing, employment, income, and also how gender plays a role as well. So one thing I wanted to bring up was there's different types of racism. So there's interpersonal racism, perhaps someone says a profanity at me, but there's also systemic racism, and this is a person's access to social and economic opportunities because of the color of their skin.
Yeah. So I think it's something that's clearly evident to you, and I think we might need to break it down a bit more to kind of see how, in concrete examples, race and health goes into play. And I think maybe we'll start with changes to the refugee policies. And I mean, it on the surface looks like it's targeting refugee population, but refugees are heavily racialized in terms of who is being forced into becoming refugees in this world. So recent changes to refugee or any other health policies, can you see examples of how race plays a factor?
Yeah, definitely. So, you know, as you mentioned, refugees are highly racialized. And so in 2012, the changes to the interim federal health program, so the federal government is in charge of health for refugees, it really impacted the ability of people to go and access critical healthcare services. And as a result, a lot of physicians are having confusion in terms of if someone comes to them and is a refugee, whether or not they can actually give healthcare services as well. And another group that's highly impacted just by race and immigrant status are newcomers to Canada. Many of them are racialized people, and so there's a 3-month waiting gap in Ontario to get access to healthcare services, to get your OHIP card, and that's also impacts a lot of racialized people in Canada.
Okay. So if you get sick within the 3 months, you know.
Yeah, so you would have to pay out of pocket, and so this is where other determinants of health also play a factor. So for instance, if you are a newcomer to Canada, more than likely you have not a job set to go, and then also as a result you may have low income. So to pay medical bills would actually impact you more than someone that had a higher income as well.
What's the rationale that's being provided by folks promoting cuts to refugee healthcare? What's the rationale? Is it saving money, or is it?
So the rationale is that by doing this, we will get people that are using the healthcare system and getting gold-plated healthcare. They won't get it anymore, and we'll save money for the healthcare system for all of us who are paying citizens. But you know, we all pay taxes, so we all pay taxes, income taxes, but also other types of taxes. So we're all paying into the system. And one other thing I wanted to actually highlight is the Hospital for Sick Children. They recently did a study to kind of see, like, did we actually save money with this whole refugee healthcare system change? And the fact of the matter was it actually cost the healthcare system more.
And I mean, you're delaying the process of getting a health preventive kind of or early intervention of something. But at the same time, you know, a large number of folks, particularly even within the Tamil community, have been here through refugee process and now contributing enormously to the economy, right? To kind of target a particular population that has actually been contributing and not been reliant. In fact, building the system is a bit insulting, I think, to a certain extent as well. So let's talk about particularly immigrant community and Farah, your work, you might have explored this thing that talk about immigrants come to Canada much healthier than the average Canadian, and then in few years their health deteriorates, right? Is that founded with evidence, or is that something that is continuing, and what are the reasons for it?
That's right. So it's a really interesting phenomenon. It doesn't only occur in Canada, but in other countries around the world, where we see that immigrants come to Canada at levels of health that are better than the rest of the Canadian-born population. Unfortunately, though, this declines within almost 10 years, sometimes 20 years, but rather rapidly for immigrants. We see this for mental health, we see this for physical health. And what are some of the reasons? We are still trying to study and trying to understand what that could be. There could be post-migration factors, could be things like systemic racism that they face, where they can't access mental health systems or healthcare systems properly, and or employment as well, precarious employment that they might have to face as newcomers and immigrants to this country, and it can put them into the situation where their health just deteriorates.
Yeah. And does racism make people sick? Physically, emotionally, mentally, but you know, obviously emotionally it has an impact with physical illness. Is there things that you're studying or coming across that talks to race being something that, you know, if somebody's feeling racism, that could lead to mental health issues?
So recently someone shared a story about a young South Asian youth in school who was bullied and actually beat up and had racial slurs thrown against him, and he experienced post-traumatic stress disorder from that incident. He kept having flashbacks and nightmares of being beat up, and absolutely it affects us mentally, physically. It's an incredible stress that it puts upon our bodies, and the mental torture of that is really difficult to deal with.
Well, I always talk about, even from my personal experience, if I had 10 years of from being a student to a school board trustee, I had to work 4 times or 6 times as harder than a counterpart who's white, male, wealthy person. And that almost equals 40 years of my life. I'm ready to retire at this point, because even those 10 years take a toll on you. And then, you know, I'm not too sure what kind of physiological impact it would have had on me until now, but soon I will probably find out, right? So this racism or fighting a systemic oppression takes a toll on you as well. So let's talk a bit about system itself. Like, you know, we talked about newcomers, refugees, immigrants, and so on. But the system is not perfect, as we know, because it's created by humans who are not perfect and who are biased in many ways. So who is it leaving behind? Who is it catering to? How is it being designed? By design, does it discriminate or leave out people?
Well, I think we like to talk about our system as being a universal healthcare system. And that's a concept that as Canadians we're actually very proud of. But I think the important question to answer is, what does that actually mean, and how does that, how is it shaped within our society? So when we look at our system, we do have universal access to medically necessary services that are provided by a physician or that are provided in hospital. So if, for instance, you're getting a surgery and there's certain drugs and things that you need that's part of that surgery, all of that is covered. But once you step outside of that hospital environment, many things aren't covered. Access to medications, that's not covered by OHIP. Things like vision care, dental care, or even supports from allied health professionals like dietitians or physiotherapists. All of these additional supports are not covered within OHIP. So if you're a racialized individual, and if there's intersecting other isms, if you're dealing with low socioeconomic status, or you're underemployed or unemployed, you're not going to have access to things like group insurance that might be able to help cover some of the costs of medications. Or so you're either paying out of pocket, or you're choosing not to fill that prescription because you simply cannot afford to pay it. So as much as we want to say that we have universal health care, because of these determinants of health like racism and race in general, we're seeing disparities in terms of who actually does have access to equitable health care.
Some may wonder why we are tying in having enough money to race. And I think there are research that shows that racialized people are highly represented, disproportionately highly represented in being in poverty, as people working in minimum wage jobs, people working in temp agencies and so on, and not having access to promotion and employment. So I think the connection is as you mentioned, it's a social determinant as well. Let's talk a bit before we take a break about services that are access related. So for example, translation or interpreters and so on. Sometimes some folks, even maybe in our own communities, may feel that this is an additional burden on the system that's being providing interpretation services. Or how critical is that, and why is that a particular right for people to access that, maybe translation, interpretation skills, and so on?
Well, maybe I'll take a stab at that first. So I think interpretation services are really crucial, particularly when you look at highly diverse centers like Toronto, where we have a lot of people with different language needs that are coming to access health services. So interpretation is one piece of the puzzle, being able to literally translate what the physician is saying between the patient and back. But I think another layer to that is cultural translation. So it's not simply a matter of knowing what the words mean in the objective sense, but also culturally, what are the barriers, or what are some things we need to navigate in order to really provide comprehensive and meaningful care to the patient sitting in front of us.
Well, that kind of sets the stage for our second and third part. I think we've talked a bit about the connection between race and health, not just health as a condition, but also health as a system, healthcare system. And we'll take a quick break, but we want to talk a bit about specifically into one of the areas of health, which is under-discussed but overwhelmingly an important problem, mental health related services, mental health related support. So we'll take a quick commercial breaks for a few minutes, and then we'll join back and take us into the deeper discussion of mental health. Welcome back. You're watching CrossRoads with Neethan Shan. We're talking about health and racism. We're marking the International Day for Elimination of Racial Discrimination, talking about this particular topic, and a special guest have taken us through the relationship between health and racism. So let's talk a bit about mental health. As we talked earlier, it's an overwhelmingly important topic for our community. Not just our community, generally most racialized communities, and any community as well. Mental health sector itself is marginalized within the health sector. So let's start with access to services, Sanjam. Do you feel that mental health services are accessible equally to everybody, or what segments are finding it more difficult to access those services?
Yeah, definitely. So I was involved with the study, and we looked at immigrants, refugees, and Canadian residents and their access to mental health care services after giving birth. So the study was specific for women. And what we noticed was that immigrant women were less likely to use healthcare services, especially for acute mental health care issues, but as it progressively got worse, they did use it, but it highlighted that there's issues of access, so whether or not people know where to go, whether people know if they have insurance to cover those services or not, and also issues related to cultural understandings of mental health, so whether there's stigma in the community or people feel that they shouldn't go until it's very, very severe. All of these played a role in decreasing the ability or decreasing the fact that immigrants using mental health care services.
So Farah, you have done some studies as well looking at access to mental health services, and immigrant population, women, youth, seniors, regardless, we've found that there is less utilization of services available. And what is your sense in terms of does it relate to having inequitable access?
Yes, absolutely. So a lot of newcomers and immigrants talk about how they really don't know anything about what resources are out there when it comes to mental health. And they're so concerned, especially when they first come to Canada, they're so concerned with trying to settle in a new country, get employed, put food on the table for their families, that they don't have time to prioritize their mental health. It's really something they can't go to the doctor about or talk to anyone about. They just don't have that luxury to spend that time to think about themselves, and it becomes a real barrier. So that the lack of economic security is one of the greatest barriers, I think, for newcomer and immigrants and racialized populations.
But we are talking about systems in general today, but it also needs to, mental health conversation cannot just have one-sided approach to this, right? So let's talk a bit about what happens within our community with respect to how mental health is perceived, or mental illness is perceived, and how it's formulated, how it's supported, and then is there a cultural, quote-unquote, cultural barriers, or the way in which some communities respond to mental health that's posing a challenge?
Absolutely. I think generally with the conversation of mental illness, you really can't have that discussion without a discussion of stigma. And I think stigma is hugely important, particularly within racialized communities. So, part of it is about accessing services, but it's also internally in terms of health-seeking behaviors. So with my research, I was looking at homeless racialized individuals with mental illness. And some of the issues that came up with respect to sort of cultural ideas of mental illness was things like supernatural understandings of what mental illness is. So for one example I can talk about was one of our participants who discussed her mental illness as being connected to voodoo that her sisters had done on her. And so she had very little trust around her family, and she wouldn't accept any support that they provided. So it was very difficult to convince her to get access to services. So similarly, in the Tamil community, we see a lot of these types of ideas of, maybe we can go to temple, maybe we can pray, and talk in those types of terms about mental illness, rather than really having open dialogue about it. I think specific to the community, there's some wonderful organizations like SAC, the South Asian Autism Awareness Center, which is really starting to build up a greater amount of awareness around certain cognitive conditions. But again, with autism, it's seen as being almost easier to talk about because it's something that happens as in birth. It's not something you can control. But other mental illnesses, is, things like depression, people often dismiss as you just need to, you just need to get over it, or you just need to sort of see the brighter side of life, sort of thing. And I don't think we put enough emphasis within the idea of mental illness is actually an illness, just as any other physical illness is.
I guess that's a thing where you start responding to mental illness by saying you're not responding well enough to challenges, or bring about another role model to say, see, this person did it, or
Exactly.
you've gone through it, and so on, right? The unique aspect of the reasons why somebody is in a particular situation, even when it comes to suicide, to understand it is not there. I mean, recently there were, a lot of discussion is about people who are poor or low income having mental health, but mental health could affect people who are well-to-do as well, people who are successful, quote unquote, as well, right? So. The understanding around that is not there. And I think we will talk a bit more on a different show about the sociological factors and the kind of community response that's necessary. But it's important to kind of acknowledge that there is that piece. When we talk about system, there's a piece that we need to do internally too. So just coming to a question around access to mental health support. I don't have, when somebody calls me about wanting some mental health support, I do not have a lot of places to refer. But there's also this thing when, would you refer somebody from the own culture because they would understand the situation better, or would that be a barrier because they would know people that are around you, right? This has been a bigger challenge for us in terms of referring somebody, and they want somebody who understands them and they understand the cultural context and so on, which Eurocentric mechanisms don't do. On the other side, there's real danger because it's not perceived. There are people who are not maintaining confidentiality about some of the cases, right? So is that your experience? What's the solution to this, or is it still going to be a dilemma?
So there's different ways of approaching it. So one way is the cultural competency piece, where you build healthcare systems or increase the training for healthcare providers to understand people's different cultures and lived realities. But this also speaks to the need that there needs to be more diverse people in the healthcare provider field for communities, especially racialized communities, to understand those nuances of how culture impacts ability to take in healthcare information, etc. And the one other thing I would highlight is that people are now trying to push towards a more anti-racist or anti-oppression form of healthcare services, whereby people understand that because someone is of a different cultural background or racial background, that there's different powers and privileges that come from that, and that also impacts access to health and power. And I think people are starting to understand as well. But yeah, definitely there needs to be greater diversity in the healthcare professional field. And I think, the challenge that you highlighted, whether or not people will feel comfortable or not, from the work that I've done, people feel more comfortable with someone of their own racial background because they feel that there's greater understanding and empathy, and any solutions that are provided, they feel like they're more actionable and they can integrate into their life.
The confidentiality piece could be easily addressed by better training for some of the practitioners, but the other part around understanding cultural complexities is hard to transfer to somebody if you haven't kind of been exposed to the same thing. Any other comments on this one around existing service?
I just kind of want to emphasize the piece around training, and particularly shift away from the idea of cultural competence towards anti-racism and anti-oppression frameworks. Some of the best models out there that do this are really able to highlight and explicitly have conversations around how race can affect individuals' lived experience, their everyday, as they're going through their daily life, and how that can have really significant impacts on their mental health. So I think that sort of directional shift is what's needed, away from this idea of understanding, okay, so we're from different cultures, there might be some things we misinterpret, but to go to a deeper level of analysis on there are structural issues here that we need to address in the process of providing care.
So is there a particular population within the immigrant communities that are more likely to be or less likely to be accessing services, seniors, women, or youth, or people with disabilities, or is it something that you're noticing in the research?
Yeah, absolutely. So usually women are actually more open to talking about mental health issues. So it's usually men that we kind of need to pull out and try to get them to access services. Absolutely, older adult populations, youth also have a difficult time accessing. It's difficult. Yeah.
So what's this patriarchy and the kind of definition of what a male figure in a community needs to be, or in a household needs to be? Kind of, you can't cry, right? And it's not just South Asian context, it's generally, but we do have certain expectations, and also that's reinforced by media and drama and TV and movies and so on. Men's mental health. I know we have a full women's panel here, which is not a bad thing, which is actually a good thing. In fact, feminism is something that helps all women and men. So let's talk a bit about the expectation of a man and the mental health support services, right? Is that something that you can elaborate on? Yeah.
Absolutely. So, within my own research that I've done with, again, the homeless racialized populations with mental illness, what we found, particularly when I was talking to service providers, some of the conversations they had with their male clients or consumers that they were working with, was that they, being homeless, having, lack of access to employment, it really gave them a tremendous sense of guilt, because they had this idea that they had to be the provider for their family, they had to take care of their children financially. And so not being able to have that, to be on welfare or to have ODSP and these types of other government supports, really impacted their sense of self-worth and their ideas around their barriers or challenges around mental illness. So really increased depression, made them feel like there really wasn't any way forward for them, because they were so dramatically failing in this role that they felt they had to fulfill as a father.
So before we go into the last segment, which we're going to be talking more about solutions in terms of, we have talked about it, but more exclusive focus on solution. Outside mental health, the other areas of health, sexual health, again, I can't find too many places where Tamil youth particularly can access any form of culturally, linguistically sensitive sexual health support, except some work done by ASAP, for example, Alliance for South Asian AIDS Prevention. What about chronic diseases and chronic conditions? Is it the same kind of analysis that you would bring to those, or is there particular areas of health that we're doing better?
So one thing I wanted to highlight, actually, now that you bring up chronic diseases, is that there's a professor at U of T, Dr. David Helchansky, and he actually has kind of seen that the city of Toronto is actually 3 cities, and where there are more racialized people, there's also higher rates of chronic illnesses as well. So this kind of highlights as well how environmental structural factors impact health. So in these neighborhoods that are poor, there's less access to fresh fruits and vegetables, grocery stores are farther away. This also impacts like what you have as for your diet as well. So all of this kind of links, income, where you live, race, access to resources. It also impacts chronic health issues.
Yes. That impacts civic engagement levels. In fact, in certain areas they have been mapping out where the pollutants are within the city, and you see that low income levels also lead to a lot of factories that pollute higher, because obviously less civic engagement, you're not fighting those things in your neighborhood, right? So ultimately, all those things are tied together in many ways. What about from your experience? There any other particular area? I know there's been a lot of focus on South Asians and diabetes and South Asians and heart and stroke, because obviously both genetically and hereditary there is a connection that's being established, but also in terms of sociological food habits and other things, right? Are we doing better in any of the other areas? There's models that we can look at?
I think, so you're right, absolutely. We're at a greater risk, South Asian population, so 3 times higher risk of diabetes, and I think a much higher risk of dying from cardiovascular disease. I think one area that we really do need to focus on, especially, is physical health, which our populations don't seem to be really engaging in.
So again, tying back to the systems, right? Our seniors want to be physically active. There is no community space. Our seniors are mostly in the mall during winter time, and the mall security isn't the most friendliest healthcare provider you can have, right? So it is, where do they go? Where is the space? And where, particularly in a weather situation where it's hard to get out for many people who are not accustomed to the weather, and the risk of falling and injury and all that stuff, right? So
so there's an excellent program that's being done by Women's College Hospital, or Women's Exchange just funding it. So they're trying to bring physical activity to mosques. So for this is specifically to South Asian women or South Asian Muslim women, but bringing it to a place where people are already there, bringing it in a way that's culturally sensitive, as well as sensitive to gender roles or all of these other issues as well. And I think that's a really interesting way of bringing healthcare interventions to where people are and where they're already interacting with each other. And I think that's a really promising practice.
And just to build on that, within the Tamil community specifically, there's an organization called the Tamil Health Association, and they also have a partnership with Women's Exchange through the Women's College Hospital, and they've recently done a series of workshops on healthy eating. So to take a group of Tamil women and to interact with, they have a dietitian who sort of goes through portion sizes and all these types of ideas, and then they get to go together and cook in healthy ways, to bake the vegetables instead of frying them, to portion out rice in the proper way, or to find alternatives like quinoa and things like that. So it really created a space for them to come together, exchange and dialogue, give each other recipe tips and things like that, but also learn something new. So I think those types of initiatives are really, really helpful and really innovative in the community right now.
I guess the system comes in here in terms of allocation of space and resources, right? If a disproportionately a community is represented highly in certain diseases or inadequate access to services, then we need disproportionately high investment of resources to make sure that happens. So we'll take a quick break for our commercials now, and then come back and we'll be talking a bit more about a strategic intervention that our communities and us and yourself as individuals can have to make things better and to kind of remove the racial inequities that exist within the healthcare system and health. So we'll take a quick commercial break. Stay tuned and we'll come back in a few minutes. Welcome back. You're watching CrossRoads with Neethan Shan. We are talking about health and racism. We're marking International Day for Elimination of Racial Discrimination, talking about health and making sure that we can start to address racial inequities that exist within health. And you've done an amazing job to establish the connection between racism and health and the impact of racism on health, and how it manifests in various forms in terms of access as well as in terms of the health conditions that we experience. So let's talk a bit about solutions. I mean, we have to acknowledge that we do have a system that is somewhat progressive than many other places in terms of having a universal health care. It's not the size of my wallet that determines the kind of care I get, to a certain extent. Again, I always have to qualify that. But talking about a lot of countries that are going to privatized healthcare system, where the government-sponsored healthcare is such in bad shape. So, starting from a strength point, let's talk a bit about how do we change. It's almost like if something is wrong in your family, you want to talk about it and address it. Doesn't mean your family is completely all upside down, right? So as Canadians, we have a role to play in terms of trying to change things for the better, and so that it does not as bad as to the next generation. And to talk about changing things, I think a lot of the time policymakers are looking at research, and so let's talk about what kind of research exists and what's the gap, and what do we need in terms of more research, or do we need more research?
Yes, we do. There are a couple of gaps in research. One of them starts with data, that we don't have enough disaggregated data, so we don't have information on separate different South Asian subpopulations or other racialized populations. We also don't know enough about immigrant status or refugee status, et cetera. We don't have that information in our big data, so we can't research it and know enough about it. We also need more research into understanding culturally safe models of healthcare. How can we institute that? How can we implement that? And we also need more program evaluation. We really don't know what types of interventions could actually work with South Asian populations and other racialized populations, and we need to be able to evaluate those types of programs and see if they're effective.
Yeah, and sometimes a particular program is designed for South Asians in total, not recognizing that South Asian means a totally heterogeneous population, let alone the population itself is probably higher than many provinces in Canada. So that uniqueness is not accompanied. So do you feel that sometimes the homogenizing of the South Asian identity becomes a problem?
Absolutely, absolutely. We often think of South Asians as this monolithic entity. Of course, we're diverse in language, culture, religion, and we really need to be taken as unique subpopulations.
Yeah. And that's how you can be more effective. Yeah. Let's talk a bit about data, because it's one of those things. I used to be a school board trustee, and we started talking about collecting data for students to see how their performance is, what barriers and so on. That's a bigger issue in terms of many resistance came from racialized communities to collect race-based data. So obviously there are people who are supportive of it too, but there's definitely a resistance, right? So collecting disaggregated data, how important is it? Do you think it'll lead to further problems in any way, or how can we make sure that disaggregated data is used productively?
Absolutely. So the US has actually been really great for this. They have decades of data based on race as well. And what they've actually seen is that some research has shown is if you eliminate racial health inequities, you could save the American economy $230 billion per year. So that's very striking. But the issue here is that in Canada, we don't know enough about the inequities based on race. So one thing that has been suggested as a solution is to link it to your OHIP card. So we already collect data in terms of where you live, your race, and your gender and your age. By adding another variable and not linking that to your personal service use, but more so in a bigger disaggregated data pool, you can start to see trends. And not only see trends about where the inequities are, but also, like Farah mentioned, actually track when we are doing well and also when we're not doing well, so we can actually allocate resources towards that population. And I think that's really a very positive sign, because if you don't track it and you don't measure it, how can you be accountable for actually addressing those issues?
Yeah. So maybe a solution that the government thinks it's providing in a general sense may not be reaching the population or may not making an impact, right?
Yeah.
So when data is collected along race, what do you see are specific ways in which that data could be used?
Absolutely. So the specific ways that it can be used in is in terms of determining policy measures. So if we know that in a certain area or a certain issue, like healthcare issue, that there is inequities of healthcare access, like I mentioned for mental health, more supports can be provided towards it, whether it be language interpretation services, whether it be creating more comprehensive care models where there's an understanding of cultural understandings. These are some ways that the data can be used.
Should that data be available for community organizations to create interventions themselves?
Yeah, right now there's something called the Institute for Clinical Evaluative Sciences, and they have a lot of data, and right now it's not as accessible to community organizations, but if that organization starts to get data, they can start to make sure that whatever they are doing is evidence-based and not just on assumptions or not just on some ideas, but like it's based in evidence.
I mean, it's kind of the chicken and egg thing, right? So when we go to meet policymakers and say, you know, we are struggling from this issue because that's what we see in our community, they're usually asking, where is the data? Where is the research? But A, you're not funding those researchers. B, you're not collecting it yourself too. So then you go home, you know, not having put the case, right? I mean, this is again an issue that's continues to be the case. And you feel that research data related stuff is a challenge for Tamil communities?
Well, I think just to comment on the hesitations that you mentioned, that some people resist the idea of race-based data collection. And I think that is a concern to think about. Particularly within the Canadian context, we've done what is often termed over-research, or we've excessively focused on the Aboriginal community and issues around diabetes and alcohol dependence. And that's created almost a very strong stigma around the community and created a lot of fear within the community about researchers in general. So I think over decades of creating that understanding or that idea of this connection between diabetes or this connection between alcohol dependence and the Aboriginal community, there's a lot of hesitation and pushback from the community saying you've stigmatized us with these issues in this process of studying the community. And so I think the really important caution when it comes to race and health is to understand race as a social construct and not go down the biological determinism route and say that if you are X ethnicity, then Y must be true about you. So we don't want to stereotype, we don't want to create these, you know, hollow ideas of what people are and how their health is, how they're experiencing healthcare and illness. But we want to, again, have the data to be able to create meaningful programs and policy changes that can really improve people's health and well-being.
I mean, from TDSP, for example, I know the school environment a bit better. When the schools identify certain racialized communities were highly represented in school, students who are being pushed out or dropped out, they were able to find intervention. But you're right, if it's only research, it'll only stigmatize. It'll say more about the problem that exists, but not say anything about what kind of intervention is needed. And sometimes they don't say why that problem exists, what historic disadvantage has been committed to that particular community, right? So it only actually contextualizes the problem in the current context, but does not say why certain communities are overrepresented in certain things. So again, you know, research is also not objective, and who does research is not necessarily, you know, and it's still heavily Eurocentric. So let's talk a bit about your plans, because we're coming to the end of the show, and all three of you are relatively young and have a vision for how you can address this, right? And I think community development is partly community together, but also individual champions, right? So let's start maybe from Farah and start from you, and then start talking about what's your plan. And we talked a lot about the issues that we have, like what do you hope to do in the next
So currently right now I'm working on a project with South Asian youth, trying to understand their mental health and service access issues. And so really trying to engage youth in this dialogue, because they haven't often been part of the conversation. Trying to understand mental health from their perspective is really where I'm trying to go there. And really one place I'm really passionate about is trying to foster community champions. If we have people from our community that can, you know, have that courage to come forth and share their experiences with using the mental health system or other healthcare systems, that could encourage people and motivate them to access care.
Yeah, definitely. Gayathri?
So similar to Farah, my expertise is around mental health as well among racialized communities. And more recently, my research interests have shifted towards primary care models, and specifically these really great innovative models that are more about interdisciplinary primary care. So not just, you know, you walking to a family physician's clinic and having just that one interaction, but to have nursing, you know, like people like nurse practitioners, dietitians, occupational therapists, everyone housed within one particular team that talks to each other and really works collaboratively to improve care. So for me, moving forward and coming from a systems and model type of perspective, the primary care model that's sort of integrated primary care with that focus, I think for me moving forward, I'm really interested in seeing how that can be applied to mental health specifically, and also to racialized communities. So how can we build in anti-racism and anti-oppression practices at the level of primary care? Because the research overwhelmingly suggests that racialized people are more likely to access primary care than any other part of the system. So if this is where they're going, then let's focus on that area. So that's, you know, where my future work is focused.
So before we go to Anjum, I want to quickly, you know, I forgot about the talking about promising practices, because it's important for us to recognize some of the good work that's happening. Can you think of any that's happening in our field that could be highlighted?
So within Toronto itself, again, we're the most diverse, racially diverse city in Canada, and so some of the really great initiatives I've seen. One is from Across Boundaries, which is this really wonderful multicultural mental health center. They take specifically an anti-racist, anti-oppression framework, and they look at the individual as a holistic person. They take into account spiritual ideas. They take into account everyday lived experiences. If you're coming from low socioeconomic background, we're having conversations on that. So it's not an exclusive focus on mental health, but also on the context and the person as a whole, which is wonderful. Another practice that I've seen, which is really great, is from Mount Sinai Hospital. They have a team called the Assertive Community Treatment Team. And this is, again, an interdisciplinary team. They have occupational therapists, they have clinicians, like physicians, psychiatrists, all these types of specialists working together. And it's done in a community outreach kind of fashion. So clinicians are going into the community, clinicians who speak your language are going into the community and helping you deal with your mental illness and figuring out what works for you on a patient-centered basis.
Great, thank you. Anjum, your plan?
So I'm interested in raising the dialogue about how racism is a public health issue. So I'm hoping to do a lot of work in my university as well as in the community on this issue. And something that I'm involved with that I'm really excited about is a Storytelling for Sexual Health research project at ASAP, so Alliance for South Asian AIDS Prevention. And so what we're trying to see is whether or not having more culturally sensitive information regarding something that is stigmatized in the community, how that can increase knowledge as well as opportunities for people to get access to greater services. And in terms of in the future, I'm really interested in how we can build solidarity among different racialized communities as well within the South Asian community, the Indigenous population in Canada, and what other communities of color. And because all of our struggles are connected and working together, we can hopefully start to curb some of these racial health inequities.
Well, that's a great finish to the show. That the need to collaborate and kind of stay in solidarity with other struggles as well. So thank you very much, Anjum Sultana, Gayathri Naganathan, and Dr. Farah Islam, for taking your time today to talk about this particularly important topic on International Day for Elimination of Racial Discrimination related show. And best of luck and best wishes in all of your efforts. So viewers, we had an amazing conversation, very deep conversation about race and health, and hope we can get your feedback as well on the topic through emails or through phone. In a week, we'll discuss another important topic, so we'll see you then. Thank you very much.